Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Fiona Ritchie.
And I'm Nik Kendrew.
We're both part of the Red Whale team.
Come with us as we make your life easier and reignite your passion for primary care.
Welcome to the 8 p.m. Sunsets Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
If you're listening on your lunch break whilst inhaling a sandwich between patients, walking the dog in the rain or in some brilliant sunshine, or hiding in your car between home visits, here's what's bubbling up as we dive in search of our pearls for the second time this month. Bubbling up this time...
Oral problems in general practice. How confident are you? It's recently been World Oral Health Day, so we thought we would consider some of the more common oral conditions that patients may present to general practice with. How confident are you in tackling the presentations of dry mouth, oral candida, aphthous ulcers and halitosis? Stay with us for a confidence boost that might just make today or tomorrow's consultations a little bit easier.
And bubbling under for next time.
Headaches, red flags and brain tumours, what really matters? Brain tumours can cause devastating physical, psychological and social problems for affected people and their loved ones. Most present as emergencies, and with no individual symptom having a positive predictive value of more than 1%, picking these up early is really difficult. Patients and clinicians worry about headaches as a symptom, but headaches are very common and brain tumours relatively rare. A full-time clinician in general practice might just see 3 cases in their career. Making a diagnosis relies on suspecting it and having a sound knowledge basis. It's recently been Brain Tumour Awareness Month, so we want to help you top up that knowledge.
Cancer and frailty, why it matters and what we can do. Frailty is common in people in whom we suspect cancer and those living with cancer, and it profoundly affects outcomes, treatment tolerance and quality of life. It can be easy to overlook when we're focused on rapid diagnosis, navigating the best referral pathway and supporting shared understanding of treatment decisions. Failure to recognise frailty can lead to over-investigation, over-treatment and unintended harm. We've got a clear, practical primary care approach to this often missed issue. We'll focus on where we can make a positive difference to support person-centred care. And so on to our second pearl of the month, and oral conditions in primary care. Now, we're likely to come across several common oral conditions which can cause discomfort and decreased quality of life for our patients. In this pearl, we're going to draw on a JAMA systematic review from 2024, alongside an older BMJ article on halitosis from 2006, to consider the management of 4 of the most common presentations, and they are dry mouth, candida, aphthous ulcers, and halitosis. Now, we're going to do things a little bit differently on this one, aren't we, Fi?
Yeah, that's right, because Nick, you've specifically asked me not to read the pearl for this time, and I'm wondering why?
Well, all will be revealed in a moment. But before that, Fi, how do you feel about oral conditions presenting to you in primary care? Is this an area that you feel confident or underskilled in?
It's a good question, but it's an easy answer. I definitely feel underskilled. And I should probably hold my hands up here and say that when someone presents with an oral issue, I immediately think, aha, they should see their dentist. Partly because that's how services are managed. And also because I think as primary care clinicians, we don't have a huge amount of training in oral health at all.
Yes, I know what you mean, but to turn that on its head slightly, what happens when a person comes to you because they have seen their dentist and they want a medical opinion? What do you do then?
Yeah, well, exactly. That's when they say, well, they told me to come and see you, that sort of situation. And then, of course, we absolutely do need to know what to do. I mean, all joking aside, that is helpful because at least the dental side of things has been taken care of and they've had a very skilled oral examination too.
Exactly. So let's work on upping our knowledge here then. And I'm sure many people will feel like you, Fi. So my thinking was that to help us land the learning, let's have 4 questions leading us up to the jackpot of a virtual £1 million. So are you up for it, Fi?
Aha, that's why you haven't allowed me to swat up then. Okay, go on then. Nothing like a bit of tension and adrenaline to help something a bit more memorable. And if it's only a virtual £1 million, then there's no harm done if I get it wrong, right?
Apart from the disappointment. But we can manage that.
You're disappointed in myself. That's the worst, isn't it?
But it'll be fine. That's not going to happen. So it's all good. So are you ready?
Yep.
Here we go. Right then, so let's dim the studio lights. And here we go for a virtual £125,000, our first question. So here it is. In the management of dry mouth, which of these statements is correct? A. Xerostomia means there is objective reduction in saliva flow. B. Prevalence of dry mouth decreases with age. C. There is good evidence for the use of oral moisturisers. Or is it D. Malic acid spray, Salivix, increases the risk of dental caries? Now, tempting as it might be to refer all these people to their primary care dentist, that is not actually the answer that we're looking for.
Okay. Gosh, that music, it's actually, I think it's giving me palpitations. So, right, I'm going to take a few deep breaths and I'm going to reason this out. So, with regarding a xerostomia, I've never really thought about objective versus objective, but I guess it's more likely to be subjective. So I'd say that one was wrong. I think the prevalence of dry mouth must increase with age. I don't think it's B. What was C again, Nick?
So option C was there is good evidence for the use of oral moisturisers.
Sounds a bit like a trap, that one. You know, those kind of MCQ type pitfalls when they say something is always and it means it definitely can't be that. Also, I've never really heard of them, so I don't think they can be that efficacious. Okay, so I'm going to say it's not C, which leaves me with D, which was what, Nick?
So option D was malic acid spray. Salivix increases the risk of dental caries.
Yeah, well, that's an acid, so that can't be good. So yeah, okay, I'll go with D as my final answer.
Okay, so you sure that's your final answer?
Yep, let's go with D.
Okay, so you're giving us answer D, malic acid spray. Salivix increases the risk of dental caries, and the correct answer is D. Well done. So you've won a virtual £125,000.
Amazing. Gosh.
Yes, well done. So you're up to the next ladder, but let's delve into oral conditions and let's start with dry mouth now. So go through that bit now. So the JAMA review from 2025 subdivides dry mouth into xerostomia, which is the subjective feeling of having a dry mouth, and salivary gland hypofunction, which is the objective reduction in the saliva flow. Global prevalence of dry mouth is high and is estimated at around 23% of the population, with levels closer to 30% in those over the age of 60, so going up with age. Prevalence is higher in those on 3 or more medications, in those with Sjogren's disease and after head and neck radiotherapy. Medications implicated include anticholinergics, antihypertensives, antidepressants, antihistamines, and antipsychotics. Symptoms of dry mouth can include dysphagia, altered taste, problems with chewing, speech changes, thirst, a feeling of oral dryness, and halitosis. Patients are at increased risk of dental caries and oral thrush. Signs may include dried secretions on the oral mucosa. We should look for asymmetry or masses within the salivary glands. NICE guidance reminds us that we should arrange a suspected cancer referral for anyone with symptoms or signs of malignancy. And you need to see our article online, Head, Neck and Thyroid Cancer, for more details on this. And that's from NICE 2015 NG12. Treatment of dry mouth is aimed at improving salivary secretions. Initial advice is to drink plenty, which would be 2 litres of water a day, and to chew sugar-free gum or lozenges. Over-the-counter oral moisturisers, such as sprays, gels, mouthwash, they may provide symptom relief, but there is no evidence from RCTs to support this. Medication-induced dry mouth may be relieved with malic acid sprays such as Salivix. Now, these are associated with an increased risk of dental caries, so patients should be advised to seek dental review and take good care with dental hygiene. After radiotherapy, systemic sialagogues such as pilocarpine may be of greater benefit. These should be used with caution in people with a history of asthma, COPD, or cardiovascular disease. Okay, so are you ready now for your £250,000 question?
Yes, I am, Nick. Yes, let's go for it.
Go on then, here we go. Right, so when managing oral thrush, which of the following statements is correct? A. Candidal infection of the mouth often causes a taste of wood smoke. B. Miconazole oral gel is the recommended first-line topical therapy. C. Candida causes white discharge on the oral mucosa, which can always be wiped off. Or is it D? Nystatin drops are the recommended first-line topical therapy.
Okay, this feels a bit more familiar. So I'm going to go, it's not A, because as far as I know, oral thrush usually causes that sort of metallic or salty taste. Option C, which was Candida causes white discharge on the oral mucosa, which can always be wiped off. Well, I don't want that one because of the always word. So that leaves us with B and D. So 2 options for first-line topical therapy, miconazole oral gel and nystatin drops. But I'm not sure with those. I feel like there was maybe an update to those. Nick, do I get a lifeline? Is there like a eliminate 2 lifeline? Yes. Can I use that, please?
You can pick a pair.
Pick a pair.
You're going to go for that?
Yeah, I'll go for that.
Okay, so Quizmaster, please take away 2 options and leave us with 2, one of which is the correct answer. And the Quizmaster has left you with... Oh no, okay. So they've given you options B and D. That's cruel. Is miconazole oral gel the first line recommended therapy, or is it nystatin drops?
Yeah, that sort of gamble didn't really help, did it? It sort of feels like a day in general practice, to be honest. Okay, so I'm going to go with B, that miconazole oral gel is a recommended first-line topical therapy, because I think I remember something about that changing. So can I have B as my final answer, please, Nick?
Okay, let's lock that in. And the correct answer is B.
Woo!
Miconazole oral gel is the recommended first-line topical therapy. Well done. So that's your £250,000. Yeah, £250,000. Brilliant.
Wow. Virtual retirement. Here we come.
That'd be nice, wouldn't it? Right then, so yes, oral thrush is a common primary care presentation and something that we are all likely to have seen or suspected in our patients. But when was the last time you really thought about the assessment and management of oral thrush rather than just signing off the nystatin script?
Yes, a very good point, Nick.
So what do we need to know about our patient with oral thrush? Well, typical symptoms of Candida include a burning sensation in the mouth and a persistent metallic or salty taste. But perhaps more importantly, we need to be aware that risk factors include immune suppression, perhaps due to corticosteroid or antibiotic use, or in patients with HIV or cancer. And other risk factors include the use of dentures, salivary gland hypofunction, and oral skin conditions such as lichen planus. The most common sign of oral thrush is white discharge on the mucosa, which can be wiped off to show erythema underneath. Less commonly, atrophic candidiasis may look like smooth red patches on the tongue, palate, or lips. Hyperplastic candidiasis can occur after chronic candidal infection. Here, the white patches can't be wiped off and have a rough pebbly surface, typically nearer to the tip of the tongue. This can mimic leukoplakia and may be associated with oral cancer. Referral for biopsy is advised under urgent suspected cancer pathways. So if you have a look at our article on oral cancer for more detail on this. Step 1 with managing oral thrush is to address the underlying cause and risk factors. This may include increasing fluid intake, reminding patients to rinse after using inhaled corticosteroids, disinfecting dentures, and managing systemic disease risks. Treatment is then with topical or systemic antifungals. The BNF treatment summary recommends for mild and localized infections, topical miconazole oral gel first line and nystatin drops second line. For persistent or more severe infections, oral fluconazole may be considered. If symptoms persist after 1 week, the treatment course can be extended by a further week, or referral to a specialist can be considered. A 2019 systematic review showed that probiotics may be protective against colonisation with oral candida. However, further research was needed to determine the dose, duration and type of probiotics to recommend. Oh, so I think I need a bit of a swig of water there.
Bit of dry mouth, Nick.
Perhaps. Right, okay. So, are you ready for your question to win a potential virtual £500,000?
I am. I mean, part of me thinks, should I even go for it? But why not? And it does make me think, you can tell this is virtual because there's no other game show in 2026 that lets you win this much money anymore, is there? I don't think. Maybe some campaigns on the radio, but even if you go on like Traitors, it's never nearly this amount of money. So I am ready for this. No, but
there are some big shows on ITV that still give it away.
Oh, are there? Okay, all right. Maybe I'm not watching the right things. Okay, let's go for it.
Okay, here we go. So, when thinking about recurrent aphthous ulcers, are they A, more common in women than men? B, most often seen in clusters in the mouth? C, more prevalent with age? Or D, initially treated with oral corticosteroids?
Okay, right, I'm going to be brave with this one. I think I've been slightly overthinking so far. So there must be topical options for oral steroids, so it's not going to be D. Clusters in the mouth? I don't think so. More prevalent with age? Yep, could be. More common in women than men? Probably. I would ask to pick a pair, but I've already used that one and it didn't help me last time either. So, okay, I'm going to say A, more common in women than men. That's my final answer, please.
Okay. And the correct answer is A.
Yes.
Recurrent aphthous ulcers are more common in women than men. Well done. So that's £500,000, virtual £1,000,000, I should say.
Okay.
Okay, so don't get too excited. So let's now think about recurrent aphthous ulceration. Recurrent aphthous ulcers, or recurrent mouth ulcers as they are also known, are common. In fact, half of us will experience this condition in our lifetime, although it's slightly more prevalent in women than men. The most common age of onset is in late childhood and the teens, around 10 to 19 years. The prevalence decreases with age.
So are there any factors that put people at risk, Nick?
Yes, so recurrent mouth ulcers are associated with a number of risk factors, including genetic predisposition, alongside nutritional, allergic, immune and systemic disease triggers. Systemic diseases associated with recurrent aphthous ulcers include inflammatory bowel disease, HIV or AIDS, celiac disease, and Behçet syndrome. Nutritional factors include reduced level of vitamin B, folic acid, ferritin, zinc, and vitamin D. No infective cause has been proven. When assessing recurrent ulcers, it helps to look for these potential triggers, as addressing nutritional deficiency or managing systemic disease might be our most effective approach. Mouth ulcers have 3 distinct subtypes: minor, major, and herpetiform. Minor aphthous ulcers are the most common, accounting for 80% of recurrent mouth ulcers. These are usually small and painful. They are either round or oval in shape and occur on the lips, buccal mucosa, and the floor of the mouth. They have erythema around them and often a greyish fibrin layer on the surface. This type of ulcer heals without scarring within 7 to 10 days. Major aphthous ulcers are like the big brother of the minor form. They are less common, larger, and tend to come in clusters of 1 to 3 on the lips, oropharynx, and soft palate. They can take longer than 4 weeks to heal, with possible scarring. Our final subtype is herpetiform aphthous ulcers. These are the least common subtype, and although they're named after and closely resemble HSV, they are not in fact caused by HSV. These are tiny ulcers which merge to form larger, irregularly shaped clusters of ulceration. These usually heal within 2 weeks and they don't scar. So let's look at some of the red flags and red herrings which may crop up in the management of aphthous ulcers. Fi, can you think of any?
Yeah, so we know that persistent non-healing ulcers in the oral cavity, that's a red flag. We should refer these along suspected cancer pathways, and that comes from NICE's 2015 NG12 on suspected cancer.
That's right. And in children with severe gingival ulceration and swelling, we should also consider primary hepatic gingivostomatitis, which needs treatment with oral antivirals.
Okay, but Nick, how do we spot that? How do we know that they're not just ulcers?
Good question. Well, HSV lesions are more likely to appear on keratinized mucosa, such as the hard palate or gingiva, which can help distinguish them from aphthous ulcers.
Okay, so how do we manage recurrent aphthous ulcers then? Is there anything that we can do?
Yes, so when treating recurrent mouth ulcers, we're trying to achieve two things: alleviating symptoms and extending the interval between episodes. And our mainstay of treatment is topical corticosteroids. And it's good news because here is a treatment that we commonly use, which actually has been shown in meta-analysis to reduce the size of ulcers and the recurrence rate. The recommended first-line choice is hydrocortisone 2.5 milligram buccal tablets, and that's from the BNF, accessed in January 2025. However, these are not always easily available, and alternative off-license options include beclometasone inhaler sprayed directly onto the ulcer, or betamethasone soluble tablets used as a mouthwash. In severe recurrent cases, we might consider a short course of oral steroids.
And what about natural remedies? Because I don't know about you, but my patients often ask about these.
Yeah, it's a really good question. Now, honey and curcumin or turmeric have been shown in meta-analysis to reduce the size of ulcers compared with controls. So, we've reached the final question. This is for a virtual £1 million. Are you ready, Fi?
To double my money? Yes, let's do it. Let's do it.
Okay, here we go. And as you'd expect, this is a tricky one. In halitosis, which of the following is correct? Is it A, chewing gums are effective in halitosis treatment? Or B, oral antibiotics are effective in halitosis treatment? Or is it C, menstruation can cause bad breath? Or D, halitosis is an early sign in renal disease?
Okay. Well, I don't mind saying I've got absolutely no idea on this one. I'm listening to those and any of them could be correct. So I don't think it's A, the chewing gums being effective, despite what adverts would like us to think. I don't think antibiotics are effective because that just wouldn't really make sense to have episodic treatment. I've never heard of menstruation causing bad breath, but it might. Maybe halitosis and renal disease, but it was an early sign. Oh, I can't remember hearing anything about either of those. So I'm going to go 50-50. I'll go with D.
Is that your final answer?
Yeah, let's just do it. Yep.
Okay. So you're saying that it's option D, halitosis, an early sign in renal disease. And the correct answer to win a virtual £1 million is C.
Oh.
I'm so sorry.
Oh.
No.
Do I get to keep the 500,000?
See, I mustn't laugh. That's bad, isn't it? I shouldn't laugh.
Do I lose everything? Yeah, don't laugh.
You've lost everything.
Just because you know all the answers. I've lost everything.
Oh no. So option C, and that is that menstruation can cause bad breath. So more on the other answers as we go on. Now, if I share the script with you, Fi, please can you help me with the rest of this teach?
Well, probably, because I don't have enough to have my virtual retirement now, so I should probably do some work.
You've got to work for it now, okay.
Let's go for it.
All right, okay. I'll start off and then you can pick up. Okay, so here we go.
All right.
So first we need to know how extensive this problem is. How long has it been going on? Does it last through the day after cleaning teeth or eating breakfast? Bad breath on waking that resolves when getting up, cleaning your teeth and having breakfast isn't classed as halitosis. We need to check that the patient's partner or a clinician can also smell it. Otherwise, we should think about whether this could be halitophobia, the fear of bad breath, the preoccupation with the idea that they have halitosis, often with repeated teeth cleaning, even when others are unaware of it.
And then we want to start looking for underlying possible causes or factors implicated in the problem. Now, the number one cause is poor dental hygiene, with local bacteria producing sulfites and amines, which we can smell on the breath. But there are a number of other possibilities we should consider, including medications such as nitrates and phenothiazines, smoking, alcohol and substance misuse, and some foods such as garlic, onion and spicy foods in particular. And there is an extensive list of systemic causes, including respiratory conditions like COPD, bronchiectasis, sinusitis, gastroesophageal reflux, and end-stage renal and liver disease. That was where I went wrong, amongst others. And we've included a full list in the written Pearl and our associated article. And amongst that list, you will find that menstruation can cause bad breath. Who knew? Perhaps everyone except me.
But you know now.
I do know now. So what management should we be advising?
Well, management should be focused on addressing underlying causes. If poor oral hygiene is present, and remember this is the most common cause of halitosis, then good oral care may have a significant impact. And the BMJ review from 2006 defines this as teeth cleaning, tongue cleaning, mouthwashes, and flossing. And alongside good oral hygiene, we should recommend lifestyle modifications to avoid those common triggers: chewing gums, mouth rinses, and oral deodorants.
Hang on, oral deodorants?
Well, yes, they are a thing, apparently. They were all assessed in a Cochrane review with no evidence that any one intervention is strongly effective, but our patients may wish to try them. There's no evidence either of a role for antibiotics, with any benefit being short-lived. And if we did suspect halitophobia, which, as we said earlier, is the fear of bad breath in the absence of actual halitosis, then we can consider clinical psychology input. So, with a virtual £0 in the bank, but a lot more confidence, here are the take-home messages for oral conditions. Management of dry mouth includes oral saliva replacement, sugar-free gums and lozenges, and promoting fluid intake.
Management of oral thrush should include treating any underlying triggers alongside topical antifungal treatments.
Recurrent aphthous ulcers are the most common acute oral presentation. Classify by size and clinical presentation and assess for red flags such as oropharyngeal cancer. We should manage with topical corticosteroids and avoidance of underlying triggers.
Halitosis has limited proven effective options, but good dental hygiene and lifestyle modifications should be tried while ruling out systemic diseases and/or drugs that may be contributing.
Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. And how do you become a member, I hear you ask? Well, if you're listening to us, then you are part of our pod. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get 10% off. And here's a small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, and it can only be used once. Red Whale Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. If you can spare a little more time, then please leave us a nice review too. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram and LinkedIn. If you want us to see something about the podcast, then please use the hashtag RedwellPrimaryCarePod.
The other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
And you can email us. Our address is podcast@red-whale.co.uk. And if you want to tell us about a change to your practice that's come about by listening to us, which we'd love to hear about, then please email us at impact@red-whale.co.uk. Until next time, I'm Fiona Ritchie.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work, so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.